So the question we're posing today, and I promise we will actually answer at the end of the session, is clinical information sharing. Have we achieved a mobile-first seamless experience? And why I say mobile-first and seamless is because when we start from who actually shares clinical information, those are the clinicians who are frontline staff, the doctors and the nurses. And what they want is to be able to share the information with anyone in the care team at the time of decision making in the most easiest and convenient way. So what we started off with, and before I dive into the clinician dream, this clinician's dream is the result of talking to thousands of clinicians over 12 years. So I give you a bit of a background how I came here. I spent 10 years in health complaint handling, and I researched 6 years specifically the link between breakdown and delay in care coordination and communication of the care team, and the impact on medical incidents and then patient complaints. So out of this research there's a lot of policy, we do understand we have a problem, but there are not a lot of solutions. So we started with a clinician's dream because ultimately it comes down to the people who are providing the care, enabling them to be able to share information safely, anytime and anywhere. Now, I want to just have a little diving into what the reality looks like. And the reality is, this is from an Australian background, but I think it is very transferable to other backgrounds as well in New Zealand. So the reality is, because there is no really easy way in all the very, very complex data silos to share between the silos, most of the doctors and nurses out there just find their own workaround. And workaround usually is we email, we text, we phone, we page, or we're using WhatsApp if we are the younger generation. So the behavior is happening whether you like it or not. So the idea is, how can we actually just give that same behavior a safe environment which is controlled? That's one part of the story. The much bigger picture is, and that comes down to my story, every time information is being shared outside the normal clinical workflow, it's not accessible to the care team that follows on. So 2 weeks later, the same patient is readmitted. No one knows what did the registrar, what was the advice that the VMO gave the registrar at 10 o'clock on a Saturday night. No one knows, because mostly your WhatsApp conversation doesn't get annotated in the clinical notes. So there's a much, much bigger picture. It is bringing it into safe environment, the mobile messaging behavior, but also pushing it back into the clinical records, because that's where it belongs. That's the source of truth. So that's where we came from Clinivid. But pushing it back into the clinical workflows needs partners. We need interoperability, opening up their systems so that we are actually able to do it, not only one way, but both ways. So I just want to introduce to you our clients. So we had a common client, which was a network of private specialists, 150 private specialists in Sydney. Now, those are doctors working across cancer care, cardiology, surgeries, a mix of different private specialists, but they share a common IT infrastructure. So they already made a decision. There are certain things where we want to work together. Having said that, they also work across different facilities. So a lot of them working in public hospitals, in private hospitals, or they have their private practice. So they have multiple locations to attend to. And one of the things they wanted is, I want to have this secure, this personal messaging, which I find really easy, which I do all the time, but I also want to link it with my normal workflow, which is they all shared Intrahealth's profile records. So our goal was, let's link it in a way that they actually don't even notice they are two different systems. And let's extend the functionality, because one reason why people love to use messaging, it's so easy to take pictures. It's fantastic because you have video capability. And I love having a group conversation where everyone knows at the same time what's going on. So that's the reason why messaging is so efficient, and it should be a normal way in health communication as well. So how did we approach it? We approached it from the end user first. So when Clinivid and this project, it always follows 3 paradigms. The first paradigm is clinician first. We know all that we have lots of stakeholders, and clinicians may not always be the decision makers, but ultimately, if it doesn't work for the clinicians, they will never use it. So there is the clinician first approach. And to automate as much as we can, we go away from the traditional commercial messaging module and structure everything around a patient. So any conversations a care team has should be around a patient. Everyone who's linked in that conversation should be part of the care team. They can leave, they can come in. So it is oriented around case, but that also allows a lot of automation and a lot of privacy and secure protection being automated. It has to be flexible, because not always everyone uses the same system, and I'm not 100% sure how the system works here, but for example in Australia you have a really sophisticated hospital-based system, but then you have allied health providers who run on paper records. Even if you wanted to use any electronic system with them, it's very difficult to get them in, but they need to be part of the conversation. So there needs to be flexibility, and as I said before, visual information sharing is becoming much, much more common, and it also finds its way into more and more into the healthcare communication, and it has to be unlimited. When you talk about having to share information, it's not about that you can only share information in a closed network. You have to be able to open it up to whoever is part of that patient's care team. Because often the patient journey starts with the GP, it goes for the private hospital sector, they might have an admission to the hospital, they get discharged, they get rehab, then they have allied health providers who look after them as well. So it's very, very multifaceted. So that's how we approached it. And as I said, to really get it into the normal workflow, we needed to partner up. And this is where I hand over to Craig.
Thanks, Katja. Yes, so it's not going to be a surprise to you that the health system's fragmented. There's been plenty of presenters talking about that over the course of these few days. Katja actually mentioned a kind of a functional list there of how they went about it. One of the things that I was particularly impressed though was how they brought together people. There was a real problem in this particular organisation, and they engaged the right people at the right time, obviously, to get the information flowing. We as an organisation, as an EMR vendor across multiple market segments, see a lot of fragmentation, and we love espousing interoperability because that's what we say. We can connect, and we want to connect. We can't do everything for everyone. But the practicalities of that, it's challenging. Where do you put your resources? While we can give someone or other organisations a list of APIs and say, okay, go to it, the reality is it comes back to collaboration. Collaboration from the EMR perspective, really understanding what the true problem is, and then actually working with the clinicians and other vendors to make that all happen. Well, she went away, and not only did she call me back, but the customer called me back in one conversation, and we talked about the problem, we talked about the solution, and actually how we were going to go about resolving it. And what transpired was actually quite an elegant solution for the end users that doesn't mean that people have to leave their system. So I think with any sort of interoperability, with any sort of integration, the key is actually that real integration and making it simple and seamless. And that collaboration has to happen very much from an end user's perspective, because at the end of the day, if someone has to do 3, 4, 5 clicks, they're just not going to use it.
As Greg said, because it's not only not interrupting the workflow, but it's also coming back to where my love and pet topic, which is safety. If the information is already there and we're not forcing people to manually enter and replicate, we're also minimizing the risk of error. So that's really, really important coming from a safety and risk point of view as well. What Craig said, it's important in the clinical workflow. So they're normal, that's where clinicians live. This is the normal place where they enter their clinical notes. But more importantly, if they are around and about and they are in a ward, they also need a mobile solution, which is a much, much simpler piece than a full EMR system. So what we did here is we mimicked messaging as far as we can. So we keep it really simple. There's an inbox, everything comes into an inbox. If people are members of multiple organizations, we can manage that, but still they get everything in one place. Also, there is, for when you open one episodic conversation, we pull out any images or videos or files that are being shared as part of that whole very, very long conversation into like an exec summary. There's a little gallery where you can just flick through. And it, again, it's to be appropriate when it says, I have to have quick decision making. Similarly, one big issue that I've found with complaint handling is there's lots of good intentions, but sometimes people just don't know. So a lot of time is being wasted by I send the information and then I have to follow up whether the person actually read it or received it or acted on it. So there are a lot that we can help to automate that. So reading receipts, knowing when the person has read it, knowing who has read it, but also proactively checking that the person is actually available. So that's a big thing, because if you send an email, if you're really lucky, you get an out-of-office response, but often you don't. If you send a message, you don't know. So we proactively check whether the person is actually available at the moment before someone puts in the effort to send him information. But the feedback has been fantastic. And what it says is, although we, for these customers, we achieved the solution that they wanted in the way they wanted it, when we look at the broader picture of, because we roll it out in different areas of the healthcare markets, there are challenges. And challenges is in any group of people, you get a certain percentage that say, I don't know, do I really need to share? Can't I just use my SMS? I love my email. Well, that's totally fine. So you have the people who just don't have the awareness or don't want to have the awareness that it's not okay to use those commercial channels for transmitting patient information. The other group, which is also we love our behaviors. You know, it's we're resistant to change. Everyone is. So if there's no incentive to change, why would I? It's working for me. It takes a bit longer, but it is working. So again, there is certain resistance from a proportion of people who just say, like, I don't want to change. But going on a more global space or on a broader space is, are they incentivized to change? Incentivizing would really help to drive change. And similarly, there is this disconnect, and I'm coming from policy, so 10 years in complaint handling also meant we had a lot of input in policy and legislative changes, and we want to provide patient-centered care with the system we have. So that's the ideal. But the reality is, we had some of the clinicians saying, I love the idea that a GP can actually ask me a question about this patient, but I don't want to. I really don't want to get this information, because when I get it, I have a duty of care, and that's my time. Who's billing me for that? And that's the reality. And we have to acknowledge that this is the reality for some of the clinicians out there. So there is a disconnect between what we want to achieve and actually what do we put in place structurally to achieve it. When we want to achieve digital health changes, technology is one really important part. And I'm really happy that, you know, we have really good partnerships with really good technology providers who share the idea that the future of digital healthcare is a connected future. But to achieve the change, the part of the puzzle is people wanting to change, people being part of it. But more importantly, there is governance. There is legislation that tells you there are very clear rules of what is acceptable, what is not acceptable. And giving the privacy legislation, the rules are there, but they are being ignored in reality. And there is leadership. There is that someone takes the leadership to say, yes, we know and recognize we have a problem. We know and recognize that we want to solve this problem, and we put money, effort and time to it to actually resolve it. We as technology providers can come with the fantastic, most greatest solutions, but if all parts of the puzzle are not coming together, it won't be a success.